Bismillah ar-Rahman ar-Rahim wa sallallahu wasallam ala Sayyidina Muhammad. Thank you very much, Professor Raj, for the invitation. Thank you for the audience also for being here, taking from your family time to come here and listen to what I'm going to say. Hopefully, I'm going to present something interesting and useful to you, inshallah ta'ala. The time is tight, so let's start right away by a quick definition of obstructive sleep apnea. Now, obstructive sleep apnea is the most severe form of sleep disorder breathing. This range of disorder ranges from habitual snoring to upper airway respiratory syndrome to eventually obstructive sleep apnea. The hallmark characteristic for obstructive sleep apnea is airflow limitation during sleep that is persistent despite continued breathing effort. Now, airflow limitation also can range from minor reduction in peak inspiratory flow, as we can see here, but this can extend to complete cessation of airflow during episodes of apnea. The main issue with airflow limitation during sleep is the hypoxemia it causes, which in turn causes interruption of the normal physiological regeneration processes that happen during sleep at the level of cells and also at the level of organs. This in turn will cause a wide range of manifestations, including cardiovascular conditions, cardiovascular disease, metabolic disease, as well as neurocognitive impairment. Therefore, treatment, or actually lifelong treatment for OSA, is a must for all OSA patients. Now, the traditional therapy for OSA is CPAP, continuous positive airway pressure. It's basically a machine that provides pressurized air into the nostril to stent the upper airway open during sleep, leading to or enabling smooth airflow during sleep. This treatment modality is highly efficacious in almost all patients of OSA. However, the effectiveness of this treatment modality is reduced by poor patients' compliance. More than 50% of patients discontinue the use of CPAP after a couple of months at most. Now, alternative therapies are available, and they are highly preferred by patients. But the effectiveness of these alternative therapies is also reduced and is variable by across individual patients. The clinical practice still lacks a tool that can identify patients, select patients that is appropriate for targeted therapy in OSA. Now, the new approach of management, the targeted therapy management approach, is based on that populations are introduced to diagnostic testing that are capable of classifying these populations into smaller subgroups of patients that have individuals having similar characteristics, including genotypic, phenotypic, and also endotypic characteristics. Treatments are then tailored to the specific needs and requirement of these characteristics. Now, we as pathophysiologists think that understanding the pathophysiological mechanisms underlying diseases in general can be extremely enlightening in terms of improving current tools in clinical practice, as well as developing new tools in the practice to select patients for targeted therapy. Now, the main goal of this lecture here is to try and understand the underlying pathophysiological mechanisms causing obstructive sleep apnea, and then link these mechanisms with available alternative therapies in an attempt to promote targeted therapy. Before we delve into that, let's just quickly browse the normal physiology of breathing. The amount of airflow is determined by two main factors according to Ohm's law in front of us: the airway resistance and the pressure difference between the upstream point and the downstream point of the airways. Now, the airway resistance is almost always constant during tidal breathing. It depends on three main factors: the viscosity of air, which is always constant during constant physical environment; the length of airway, which is also constant in adult patients; and lastly, the radius of the airways, which can change during increased and decreased level of parasympathetic activity and sympathetic activity. But during tidal breathing, the radius of the airways also remains constant. So if this part of the equation is constant, the main part of the equation that determines airflow is the pressure difference between the upstream point and the downstream point of the airways. These points are the nose and the lungs, respectively. There are no barriers between the nose and the atmosphere. Therefore, air particles can move freely between the atmosphere and the nose and vice versa. Therefore, we can say that the pressure inside the nose is equal to the atmospheric pressure, 760 millimeter of mercury. We can also say this in other words. It's around 0 centimeter of water relative to atmospheric pressure. So this is fixed. This is always high. What actually determines airflow is the amount or the value of pulmonary pressure. Pulmonary pressure, or the pressure inside the lung, is determined mainly by the size of the lungs. During inspiration, the respiratory pump muscles is activated, and this in turn will cause the chest wall to distend, pulling the lungs with it via the pleura. This will increase the size of the lungs and reduce the pressure inside the lungs. This in turn creates a negative pressure inside the lungs, and consequently a pressure gradient between the lungs and the nose. This enables smooth airflow because air particles move from the compartments with higher pressure, which is the 0 centimeter of water here, to compartments with lower pressure, which is the -6 centimeter of water, which is one of the, which is the normal pulmonary pressure. Now, the pulmonary pressure can go as low as -30 centimeter of water relative to atmospheric. It's a really huge number. The question comes here: where is the missing piece that causes sleep disturbance in OSA patients? And the answer is going to be in this slide and the next couple of slides, inshallah. There is a segment in the upper airway that's called the pharynx. The pharynx lacks any bony or cartilaginous support. Therefore, and this is to accommodate for the multiple functions it performs, including deglutition and speech beside breathing. This makes the pharynx susceptible to collapse. In other words, or actually, let's remember that the pharynx lies between the nose and the lung. So if the pharynx in the middle collapses, no airflow can pass from the nose towards the lungs. Logical. We can say, in other words, that the pharyngeal pressure should be part of the pressure gradient between the nose and the lungs. In other words, actually, the pharyngeal pressure is what determines the amount of airflow. The lungs pressure is always negative. The nose pressure is always around 0 fixed. The pharyngeal pressure determines what the amount of airflow. Now, pharyngeal pressure itself is determined by two different forces: collapsing forces and opening forces. The balance between these forces is what determines the exact value of pharyngeal pressure. Now, any anatomical deficit or mechanical deficit that occur in the upper airway will cause imbalance in these forces, leading to increased pharyngeal pressure, leading to increased airway collapsibility. There are many reasons that can cause this, including narrow airway, for example, tonsillitis, adenoids, also confined craniofacial areas in the head and neck can also cause this, for example, in Asian populations, and so on and so on. Now, this feature of the upper airway, pharyngeal collapsibility, can be measured in research lab using an indirect technique called the pharyngeal critical closing pressure. Now let's imagine together that the pharyngeal pressure should be normally around -6 centimeters of water, and the nasal pressure is around 0 centimeters of water. What would be the pressure at the nose that will cause a complete cessation of airflow? It's the pressure where there is no pressure gradient at all. So it should be, the nasal pressure should be equal to the pharyngeal pressure so that the airway breathing is stopped completely. Now we can measure that in research lab. We can measure this nasal pressure at which airflow stops completely, and we can consider it as a representation of the pharyngeal collapsibility. This pressure is normally, as I said, below -5 centimeters of water, but it can go up to -2 centimeters of water in mild airway collapsibility. Anything above -2 centimeters of water is going to be considered either moderate or even severe airway collapsibility. All OSA patients, without exemption, have some anatomical deficit causing poor airway collapsibility for them. All of them, 100%. This is actually considered the main pathophysiological mechanism by which OSA develop. And we can also name that as the first endotype of OSA. Now, from that, let's move forward to the pharyngeal muscles. The main opening force, so we spoke about the collapsing forces. The main opening force for the pharynx is the activity of the pharyngeal dilator muscles. These are the genioglossus, tensor palatine, and the hyoid muscle, but mainly the genioglossus muscle. These muscles receive recruitment drive from the respiratory center in the brainstem, but they also receive reflex drive from the intrathoracic pressure. And this is really important for us when measuring the amount of activity of the pharyngeal muscle activity. During sleep, the activity of pharyngeal muscle goes down for all people, but it goes down to a pathological extent in people with OSA. In research lab, we can measure this using two different techniques or expressions, muscle responsiveness and muscle effectiveness. I'm going to explain this on the slide. Right. So we have this trace here. I'm not sure if everybody can see that, but hopefully yes. This trace has three different arms: airflow, intrathoracic pressure, and then the activity of the genioglossus muscle. The muscle responsiveness is the amount of muscle fibers recruited per unit increase in intrathoracic pressure. So for this patient, he's starting to experience some hypopnea. This in turn initiated some increase in intrathoracic pressure. This in turn initiated some increase in muscle activity. This is what we call responsiveness. Now, effectiveness is one step further, is the amount of airflow achieved per unit increase in epiglottic pressure. And for this patient, for example, we can see that the responsiveness is good, but this responsiveness did not cause any effectiveness for airflow improvement. So these two measures can also be, as I said, measured. These two criteria can be measured in research lab, and we can use them to classify OSA patients who have to subgroups who have either high muscle activity or strong muscle activity, or those who have poor muscle activity. We can consider this as the second endotype causing obstructive sleep apnea. Now, what happens if the intrathoracic pressure started to increase during episodes of airflow limitation, but then airflow did not recover? So what I'm saying, what does happen when there is a persistent inadequate ventilation despite increased pharyngeal pressure or intrathoracic pressure? What happens is that the brain gives a signal to itself to initiate arousal, a cortical arousal. This cortical arousal attempts to recover the activity of the genioglossus muscle and in turn recover the pharyngeal collapsibility, the pharyngeal function, and airflow. Now, this mechanism is a protective mechanism from apneas. But the problem when this mechanism happens frequently during sleep, this can disturb the normal ventilatory control system. And this can also reduce the amount of stable sleep that is related with better performance and better regeneration process. We can consider this as the third endotypic feature or endotypic mechanism causing OSA. The arousal threshold can be measured also in research lab. And I'll explain that again in the same trace. As we can see for this patient, he's experiencing some airflow limitation here. This triggered increase in epiglottic pressure or intrathoracic pressure. The point of epiglottic pressure at which, or the nadir point that the patient can reach without eliciting an arousal is called the arousal threshold. Now, whenever this threshold is increased, became more positive, it means that the patient is becoming more sensitive to airflow limitation. It means that he's going to wake up more frequently during the night. So around 35% of patients with OSA complains of poor arousal threshold or increased or more positive, low arousal threshold or more positive arousal threshold. The next endotypic feature or mechanism by which OSA develop is called loop gain. Now, the loop we're talking about here is the ventilatory control system loop. The main function of that loop is to stabilize breathing during wakefulness and during sleep also. There are three main components for this loop. One, the lung, which does the exchange of gases between the atmosphere and the body. Two, the brain stem or the respiratory center in the brain stem, which receives information regarding the amount of oxygen and carbon dioxide in the blood and adjust breathing accordingly. And three, the cardiovascular system, which transmit the signals of oxygen and carbon dioxide levels between the brainstem and the lungs. Now, the expression gain means the amplification ratio in any feedback loop. And by that we mean the output relative to the input. In normal circumstances, the output needs to be less than the input, and this ratio needs to be less than 1, so that breathing continue to be stable. I'll give you an example on this picture again. So the lower panel have some airflow. Well, firstly, it starts with eupneic breathing, and then some minor airflow limitation follows. This initiates some increase in airflow, followed by a less reduction in airflow, and then breathing is stabilized after that. When this system becomes oversensitive, when the loop gain becomes high, what happens is that responses to airflow limitation becomes exaggerated. So just minor reduction in airflow will induce a huge increase in airflow. This in turn will induce a huge decrease in airflow. This in turn will induce a huge increase in airflow, and so on, until patients either wake up or recover from the apnea event. So this is also present, the high loop gain is also present in around 35% of OSA patients. So from what I said until now, we can categorize these pathophysiological mechanism into anatomical factors, which is present in all OSA patients, and then non-anatomical factors, including the weak pharyngeal muscle activity, the low arousal threshold, and the high loop gain, which is present in around 35% of patients, each one of them. Targeted therapy starts by knowing these characteristics and then select patients that the outcome of these therapies is expected to be favorable. Well, CPAP fits all and is going to fix everything in a direct manner, but we want to escape this. The main alternative therapy for obstructive sleep apnea is oral appliances, basically devices that are worn inside the mouth to protrude the mandible forward to give more space, increase the pharyngeal space, therefore lowering the pharyngeal pressure and improving airway collapsibility. Positional therapy help in redirecting the forces of the pressures inside the pharynx. Weight loss and lifestyle changes can also help the mechanical imbalance and improve the mechanical imbalance in airways. Nasal improvement, such as nasal surgeries or corticosteroids or whatever the treatment that can help improve the nasal passages are also helpful. And the most aggressive treatment is surgery to correct upper airway mechanical deficits or nasal deficits or even mandibular advancement surgery. Now, all these treatments target anatomical collapsibility, weak or poor pharyngeal collapsibility. If we're going to use these alternative therapies in patients with non-anatomical causes of OSA, it's not going to help much. This slide here demonstrates 2 or 3 of the main treatments that target non-anatomical therapies. These include the hypoglossal nerve stimulation to improve the pharyngeal muscle activity. Muscle training is also an option, but the research around that is not much solid. Oxygen therapy has been showing really promising findings in treating high loop gain, and pharmaceutical therapies can target low arousal threshold. Now let's summarize all this in one slide. We have 100% of OSA patients that have anatomical imbalance, sort of anatomical imbalance, but the severity of that anatomical imbalance on the pharyngeal or the pharyngeal collapsibility can be either moderate, mild, or severe. Patients with severe airway collapsibility should be treated with CPAP. They are more to gain benefit from CPAP therapy. On the other end of that spectrum, patients with mild airway collapsibility should be targeted with non-anatomical therapies. Now, patients with moderate airway collapsibility are always difficult to treat. Those with purely moderate airway collapsibility can be treated with CPAP, of course, but other anatomical therapies can be effective, including surgery of the upper airway, oral appliances, et cetera, et cetera. And patients who have moderate airway collapsibility superimposed with non-anatomical mechanisms causing obstructive sleep apnea can be treated with everything, but including the combination therapy, at least to reduce the amount of CPAP pressure or to improve the patient lifestyle. That's all for me. Thank you very much for listening. If you have any comments, please have a picture for this, and I'm going to be happy to read them. Any questions?